Welcome to Wellspring on the Air. I'm Lindsey Steffen, a therapist at Wellspring and the host of today's show about OCD, obsessive compulsive disorder. So here with me today is Carlos Izquierdo. He is one of our interns and he has been an awesome addition to the team during this year. So thank you for being with me today, Carlos.
Thank you for having me, Lindsey.
Yeah. So why don't you tell our listeners just a little bit about yourself, kind of your experience and what you've been doing with us at Wellspring?
Well, I am a student intern, as you said. I'm completing the Master's in Mental Health in Albizu University. I started working with Wellspring in September 2020. And I've been, before that, I was working for a while with autistic children and people, especially minors that suffer autism, ADHD, and similar disorders. And I was working as a behavioral technician, providing behavioral therapy to this population. And then once I started my master's in mental health, I decided to take the route to become a mental health counselor. And well, now I'm in my final semester and excited to graduate. And I'm already seeing clients as an intern. I'm doing my practicum hours, and it's been a really enriching and illuminating experience because I've been able to see with actual clients whatever I was learning theoretically now is becoming real with the clients, and it's been a delight to work with them.
Awesome. Good. Well, I'm so glad that you've had a good experience. And yeah, it's true. You have all this head knowledge, but applying it is a much different story. So yeah, and we've been so happy to have you. So, and yeah, I know that OCD is a special niche working with that kind of anxiety disorder. So we're going to just dive in, and our listeners maybe they've heard of OCD and there's stereotypes from movies, but let's really talk a little more clinically. What is the true definition of OCD?
Yeah, as the label says, obsessive compulsive disorder. So OCD is made up of two parts. One is obsessions. Obsessions are intrusive thoughts that are experienced as intrusive. They're persistent, they're recurrent, and they cause a great deal of distress in the person. It can be a feeling of anxiety. It can be a feeling of disgust. It can be a feeling of incompleteness. But those thoughts trigger those emotions, and then the person, as a response to those emotions, tries to get rid of that by performing what is called compulsions. Compulsions are a sort of behavior that is meant to reduce the anxiety, the disgust, or the nagging feeling that those obsessions cause. And the ironic thing about compulsions is that even though they may bring some temporary relief to the person performing the compulsions, in fact, they don't solve the problem because the obsession then comes back and then causes more anxiety. And then the person finds his or herself trapped into a sort of loop or a vicious cycle of obsessing and then performing a compulsion, obsessing, performing a compulsion. And actually, it has been shown that the more the person performs the compulsions, the stronger the obsessions become. So it's really it's like a loop. It's like a loop. Yeah.
Yeah, it makes sense. Yeah, the more you do it, the more you have to do it. It's kind of like, I even think of when we work with drug addiction, it's kind of like, oh, you get that high and you're good for a little bit, but you always have to go back to it. It never stops. It never satisfies, and you're good to go. So I kind of see some of that loop that you get stuck in behaviorally.
Yeah, and that's an interesting. It's interesting that you brought the case of addiction, because there's a lot of similarity, but there's one important difference between addiction and OCD. Usually, addictions begin by being pleasurable. OCD is never pleasurable for the person who's having those obsessive thoughts. Actually, the person just he or she wants to get rid of those thoughts. Whereas, the addict, at least in the beginning, the early stages of the addiction, enjoys whatever the substance or
yeah, they're getting more of that dopamine release. But yeah, it's performing the compulsion, whether washing your hands, or I know we'll go into some actual examples in a minute, but yeah, it was always very anxiety producing, I hear you say.
But there is a big similarity between addiction and OCD. OCD is like similar, like addiction is OCD like.
Okay.
But there are also some differences. Now, what are we talking about? Let's use some concrete examples. So there can be as many obsessions as there are people. Any thought can become an obsession. But through studies, and these studies have been conducted not only in the United States, but across the world, we have been able to find that there's about 3 or 4 dominant types of obsessions and compulsions that account actually for about 70% of all cases of OCD. And that tells that there may be a really strong genetic component, because we can see that through different cultures. It tells that there's a strong genetic component in OCD. Now, one of the most common cases of OCD is what is called obsessions where cleaning or contamination. So there are people that are extremely afraid of being the victim of some kind of contamination. It can be either getting a virus, touching a doorknob and getting infected or by germs, and then they're constantly worried about that possibility. And usually the compulsion that is used to try to solve that is just it's called cleaning compulsions. For example, if you're afraid of touching doorknobs or touching, I don't know, tables in restaurants because you think you're going to get a virus, then those people may, go to the bathroom many times, wash their hands over and over again, with the hope that they will make sure that there isn't the slightest possibility that they get the virus. So, and then, but what happens is that it doesn't work. Like, the more they wash their hands, the more they get obsessed with getting a virus. And there's a big mystery there. And apparently it is also connected with the brain. We're going to talk about that later. But now I would like to mention another case. So that's cleaning compulsion, cleaning obsessions and compulsions. But there's also harm obsessions. And it's people that are concerned about getting harmed themselves or harming others.
Yes, I've had some of those cases. And even just in case we have a listener who's maybe very disturbed, I mean, I've had clients who are loving parents, but even have a compulsion or a thought that, what if I hurt my child? What if I'm cooking in the kitchen and I just stab them? And that's, of course, extremely disturbing. But we have to learn that's not your thought at all. That's OCD sending you that anxious thought. And of course, there's people who are violent or dangerous, but with OCD, with this kind of thinking, you're really not. You're not wanting to do it. You're in fact extremely distressed by it.
Yeah, exactly. And actually, as you can see, OCD is very related to the difficulty in accepting uncertainty. Because people that are obsessed with, well, what if I want to hurt my children? It's not like they are 100% certain that they want to hurt the children, but just the fact that there is a possibility, even remote, just put them in distress. And then they engage in all sorts of checking behaviors. For example, the obsession can be, well, what if I leave the oven connected and there's a fire in the house and my children die, or maybe people in the neighborhood will die. And then those people need to go back and make sure that the oven is disconnected. Now, everyone has done that, once or twice, but if you do that 30 times, 40 times, 50 times a day, then your life is going to suffer, because then it seems like everything starts, revolving around your checking behavior.
Right. It starts to interfere with your normal life. So you're late to work because you had to go back 30 times and check, or we start to see that it's distressing in your everyday life. You can't maybe maintain even relationships, things like that. So
exactly. Actually, among the criteria for knowing if the person suffers from OCD or not is how much time do you spend engaging in compulsions. Usually an hour or more will be considered a case of OCD. Of course, there are different degrees of severity. There are people who only spend, around 1 hour, but there are people who will spend most of the day just checking if the oven is on, which is quite a very distressful thing. That's another one. There's also the obsession with symmetry or order. There are people that are so obsessed with symmetry and order. This could be with things around them in their environment. It could also be mental. It doesn't have to be with actual things. But people that are these are people that are considered very perfectionistic, and they need things to be organized and put in a certain order. And then if they don't get that organization, then they get this trigger. They are triggered with this tremendous anxiety, and they feel the urge to make sure that things are done in the right way. in the proper
You
way.
can get very irritable. Maybe, if you have kids and they move things or upset that order and symmetry, you can start to be actually mean to them, but it's coming from your anxiety. Not that they're a mean person, but they're so distressed that things are not just so.
Absolutely, absolutely. That can even be connected to. Although this is another type of not type, but another type of obsessions. But it can be connected to prayer. For example, there are people who think that they have to pray in a certain order. If they don't pray in that order, then the prayer is not valid, and then they have to go back and pray again until they feel that they get it just right. And they can spend hours repeating the same behavior. So it's really distressing. Now this connects with a fourth category, which is the category of forbidden thoughts or taboo thoughts. These are like thoughts about aggression or sexual thoughts, or even religious thoughts of blasphemy or sin. And this can be seen. It's very common to see this among religious people. Obviously, people that are for them it is really important to feel that they're in good standing with God, that God is not disappointed at them, and they find themselves questioning, well, did I sin? Am I how is God looking at me? And then they have all these recurring thoughts about being pure before God. And then there's also another kind of OCD that I found out when I was doing my research for this interview, which is not in the DSM-5, but a lot of clinicians mention it. They call it existential OCD.
Yes.
Existential
Okay.
OCD. And
Please
these are
explain
people.
that, because I find that one very interesting, and I've actually treated it with several clients, but it's hard to pinpoint because it's not kind of talked about as a normal OCD type, but it exists for sure. So go for it.
Yeah, people that are obsessed with deep philosophical questions, and they feel like they need to solve those questions in order to get rid of this sense of anxiety, uncertainty, or this nagging feeling of incompleteness. Like, I have to solve those questions. And those are usually really hard questions that no one has figured out an answer for. So they find themselves looking on the internet, looking for interviews, talks, reading, underlining books, like trying to figure out a solution. And then when they think they have the solution, then they hear someone who makes another comment that question, and then they have to start all over again to try to solve that mystery. And here we're talking about philosophical issues like, does God exist? Or are we free will versus determinism? Are we free to choose? Or those are perennial questions of philosophy that no one has figured out, and somehow they feel the need to solve them. And they're trapped in this constant pattern of obsessing and compulsing. And that's a very interesting case, because, as I said, it's not included in the DSM-5. I don't know if it will be in the future, but
and those clients, it's hard because because of movies and TV, we think of OCD checking the lock, washing your hands, these very kind of the stereotypical rituals. But there's, like you're explaining to us, I'm so glad you are, there's such a spectrum. And so some OCD, there is no actual maybe behavioral outcome. It could just be all mental. So some people will Google about God, existential things, but some of my clients just ruminate on it in their head, and the behavior is being just stuck and being so distressed they can't do their normal life things. Like at school, I'm still thinking about this. So that's a really interesting point. Well, Carlos, we actually have to take a quick break. This is so good. We could talk forever. So let's go ahead and take a quick break. And I'm Lindsey Steffen with Wellspring on the Air. We'll be right back. Welcome back to Wellspring on the Air. This is Lindsey Steffen. I'm here with Carlos Izquierdo, and we are talking about obsessive compulsive disorder. So if you're just joining our show and you missed the first half or you came midstream, definitely check out your favorite podcast channel, Wellspring on the Air, or go to our blog page, wellspringmiami.org, and just search for this topic, obsessive compulsive disorder, and you can catch up on what you've missed so far. So we've talked through what is OCD. We've talked through obsessions, compulsions. We've given some examples of different types. And we just were talking about how there are rituals, the things we actually play out with the compulsion, the behavior. But also we were talking a little bit just about the existential OCD and how it can be solely just in your brain worrying about, is God real? What is the rapture? All these kind of things I've had clients get obsessed with and just get stuck in that thought loop. So Carlos, we'll continue from there.
And by the way, these people it's not like they're enjoying investigating these questions. They don't want to have them. They want to get rid of them. And that's the difference between someone who suffers from existential OCD and someone who makes a career, he's like a professional philosopher.
Right. They love it. They thrive on it. That's
you know what
different.
I mean? It's their calling, it's their career. In this case, it's someone who doesn't want to think about these issues, but those issues are somehow they impose themselves on the person's mind, and they feel that they have to wrestle with them.
Yeah. Good distinction.
And as you said, rituals can be internal. They don't have to be some kind of external behavior. That's why sometimes it's tricky to diagnose OCD, because usually you say, well, you will tell if someone suffers from OCD because of the ritual, but if the person doesn't have any external rituals, if everything is in the mind, and it could be like counting, praying, saying something quietly, or even trying to think about something, like forcing your mind to think about something, or to have like a mental image that's to somehow neutralize the obsessive thought. You cannot see that externally.
No.
If you have to wait for the client to tell you, and sometimes clients don't want to share. Who would want to share that? You know what I mean? It's very for them it's embarrassing. Yes. So it's really hard to tell. So I wanted to move to some statistics. We know that OCD is more common than we think. Actually, the World Health Organization in 1996 published for the first time a list of the top 10 disabling conditions, and OCD was one of them in the world. They consider it is considered that about 2% of the world population suffers from OCD, and here in the United States, 1 in 40 people suffer from OCD.
So that's more common than people imagine, I'm guessing.
That's a great amount of people. Now, why would it be that we don't see as many cases of OCD? It's because people that have OCD are very good at hiding it.
Yeah,
they're very good at hiding it. Now, one may wonder, well, what's the cause of OCD? Is it biological? Is it sort of learning or a cultural thing? Well, it's actually a combination of biology and learning. We know that people that suffer from OCD, there are certain regions of the brain. For example, there's a region in the brain that reacts to uncertainty, and we know that people that suffer from OCD has a lower threshold for uncertainty, which means that it takes less uncertainty for them to react with anxiety.
Okay.
Like that part of the brain is triggered more easily compared to the quote unquote normal brain. Okay. So they will get really anxious about something that other people wouldn't, consider a big deal.
Right. My OCD clients, they tell me, they're like, I think they'll have a thought that I would maybe get anxious about, but in a minute it would go and I'd move on with my day. But that thought comes to them and they are unable to move past it. It's like it's cemented into their brain and they cannot focus on something else until they quote unquote take care of it or do whatever compulsion.
Yeah. So some people call it sticky thoughts.
Okay.
Like, stuck in your mind and you don't know how to get rid of them, except you feel like if you don't perform the compulsion, you're not going to be able to get rid of it. And then there's another region of the brain that is related to it sends you it makes you, when you finish a task, you get the feeling of completion. Now, what happens with people that suffer from OCD is that part of the brain that is not working properly. They don't get that feeling of completion. Okay. And that drives them crazy, because if you wash your hands and you know rationally that you completed washing your hands, but you don't know emotionally that you completed washing your hands because you're not getting the feeling of completion. So it is very confusing and they feel, oh, okay. So yeah, I think I washed my hands, but I feel like I didn't wash my hands. So I have to do it again. Yeah. And they're caught in that cycle. It's really distressing for them. So there is this predisposition, this biological predisposition, but that in itself is not enough for someone to develop OCD as a disorder. There have to be there have to be triggers in the environment. There have to be a history of learning, and usually, a lot of a great percentage of the people that suffer from OCD develop it in childhood. Other people develop it in mid or late adolescence. So those are the most common. Sometimes it develops abruptly, and sometimes it develops gradually. Right. Now, what are the causes? Why can someone develop an obsession with cleanness versus harm, or existential OCD versus symmetry?
Great question.
Well, we don't know. There can be many factors involved there in the history of the person. Sometimes you can get a hint of why, if we know what is important for that person. If for you it is important to be an ethical person and to have a good moral character, anything that could threaten that will be possibly a source of obsession. If for you being, if you're very religious and for you, being faithful to God is really important, and anything that could threaten that can become an obsession. But we don't know for sure. What we know is that when it develops, it tends to, there's a difference between the precipitating causes and the perpetuating causes. So whatever caused the OCD originally doesn't have to be necessarily what maintains it over time.
Okay. So I'm hearing there's the genetic component where you're kind of predisposed for this type of anxiety disorder, but then also there's environmental triggers or maybe even modeling. If it's genetic and a family member, a mom, dad, whoever also have some type of anxiety disorder or specifically OCD, they're learning both through the modeling of that and then also just that predisposition genetically.
Yeah, exactly. So that combination, and there's one of the experts of OCD in the United States. I was watching an interview with him, and he used an example that I think is very illustrating. Someone who to tell the difference between precipitating and maintaining factors. Say that you are a teenager and you are very unassertive, and your peers start smoking, and you start smoking because you're not assertive, so you want to go with the majority. Yeah. And now you have an addiction to nicotine, and now you're 35 years old. And you want to get rid of it. If you address the lack of assertiveness, you're not going to solve the problem, because the lack of assertiveness may have been in the origin, but it's not what is keeping the disorder now. Got it. There is a chemical dependency now that is keeping the disorder. So even if you go back into the past and you address whatever initiated the OCD, you may not necessarily help the client overcome the disorder, because maybe that other factors are maintaining the disorder now.
Yes, so, new things have developed as their life has changed, as they're now having an adult life experience.
Exactly. There is also the difference between content and form. I think we already touched on that. Like content, it can be, any, whatever the theme of your OCD is, whatever the theme of your obsession. So that can vary from person to person. But that's the content. But the form is always the same. Obsessions that cause great distress and compulsions to try to get rid of them.
It's like the same formula, just different situations or scenarios.
Exactly.
Okay. Exactly. All right. Well, let me ask you a little bit, just because we are Christian counselors here, or counselors who are Christian, whatever you want to say, but tell us a little bit about faith and OCD. Any intersection there?
Yeah, there's a lot of stigma actually among people of faith. And not a lot of, even sadly, a lot of religious leaders or pastors are well informed about OCD. And the kind of counseling that people receive from pastors or priests is not always scientifically informed. And they see OCD not necessarily as an illness, but as they try to get some kind of spiritual meaning or theological meaning out of OCD, when in fact, what research shows is that it's more like a neurological / psychological condition, that it doesn't need to have a lot of spiritual meaning to it.
It's a medical condition. Yeah. The brain is sick. Your brain's an organ, just like if your lungs or your heart gets sick, your brain gets sick. And so you're right. It's not a lack of faith or trusting God, which sometimes maybe, unfortunately, churches will perpetuate that, when you're like, no, actually, we can look at the brain scan and see that the brain as an organ is not functioning correctly.
Yeah, you don't try to. There was an OCD. Someone who was given a talk on OCD, and he was recovering from OCD, but he suffered from scrupulosity, because scrupulosity is the name that is used for OCD when it applies to a religious context. And he said that, well, I don't look for a theological meaning behind my high blood pressure. In the same way, I don't think why I should look for a theological meaning behind my OCD symptoms.
Wow, that's a great example.
Yeah, it's just a brain condition. And yes, you can be both a person of faith and suffer from OCD. They are not incompatible, and they are not a sign of that you're the lack of trust, or that you are a sinner. Or even, I've heard that one a lot too. The OCD somehow occurs to the person.
Yeah. Okay. I love that you said that though. They're not incompatible. You can be a person of faith and suffer with OCD, just like you can also suffer with diabetes or low blood pressure, whatever, high blood pressure. So, yeah. Well, Carlos, we just have a couple minutes left. So I want to ask you, because this is important. We want to give hope to our listeners. Can
Yeah.
OCD be treated and how? So why don't you briefly give us an overview there?
Yes, OCD can be treated. And actually, there exists the standard treatment for OCD is called exposure and response prevention, ERP. And there are other modalities of therapy. Usually, they're being combined lately: ACT therapy, acceptance and commitment therapy. And actually, there is a good amount of research showing that it really works. You may need medication in the beginning because depending on the severity of your OCD, you may need medication in the beginning, and medication also works. But what we have found is that therapy has the most profound and lasting effects. Now, what we need, the key for this is, first of all, to have the right diagnosis, because OCD can be confused with other conditions. And once you get the right diagnosis, it is really important to find someone who specializes in OCD, because there aren't many of them, but it's really important. And yes, it can be treated and the person can recover and the person can have a meaningful and productive life and can learn to deal with his or her OCD. Actually, there's an expert on OCD that says that by recovering from OCD, you have to learn how to deal with uncertainty. And after you recover, you're not going to be normal. You're going to be better than normal. Because you're gonna learn to deal with uncertainty even much better than quote unquote normal people.
Yeah, than the average person. Oh, that's so hope giving. Well, thank you for that, Carlos. And I can attest to that clinically. I've treated people with OCD or different comorbid disorders. And absolutely, you get to a place just so like with depression or any other disorder where you can live a happy, meaningful, fulfilling life, have normal relationships. It just takes that work and really healing whatever's going on in the brain. So all right. Well, it's time to close out the show, Carlos. Any last thoughts before we wrap up?
Well, I just would encourage anyone that may think that he or she may suffer from an OCD or someone in the family to look for professional help. There is good treatment. The treatment works. So, and yeah, that's what I would say.
Awesome. Thank you, Carlos. Thanks for joining me today and teaching all of us a little more about OCD and what we can do if someone we love or ourselves were kind of resonating with this show and noticing maybe I should reach out and get help. So again, if you joined our program midstream, you can go ahead and find the full complete episode on our podcast channel, Wellspring on the Air, or you can go to our blog page, wellspringmiami.org. Again, today's title is Obsessive Compulsive Disorder. So encourage us, let us know you're listening, drop us a line. You can email us at ontheair@wellspringmiami.org. Send any comments, questions, or maybe if you have a request for a show you would like to hear, definitely let us know. So it's time to wrap up. This is Lindsey Steffen with Wellspring on the Air, because hearts and minds matter.